the brain. And we're going to start very concretely. The brain is about 1 liter of volume, so your little milk container, okay? And it weighs about 3 pounds. So if your average person weighs 150 pounds, 3 pounds out of 150, right, is about 2% of body weight. So the brain is not a big chunk of our body. However, it's a pretty important part of the body because every time your heart beats, about 15% of that is going to feed the brain. So it's only 2% by weight, but it's 15% by heart output, 20% by oxygen consumption. So we breathe, and 1/5 of every breath is to go to the brain. And that's in part because during the night, all the other organs are pretty quiet, especially our legs that use a lot of oxygen when we're walking. They're not doing anything, so they don't need a lot of oxygen, but the brain is on all 24 hours a day, right? So that makes up part of it. So 15% cardiac output, 20% of oxygen, and 25% of energy consumption. So everything you eat, 1/4 of that is essentially destined to feed the brain. So keep that in mind the next time you have some poutine. So the brain itself looks something like that. That would be the left half of the brain. And it has different parts. So it has a frontal part in the front, so right and left half, but you're looking at the left frontal. You've got the parietal right behind it. You've got occipital in the very back, and then you've got a temporal lobe here. And we are going to come back to these areas because they do serve different functions, and when we talk about different types of dementia, the name will matter. So what is the brain made up of? It's made up of brain cells, or what we call neurons, and you have between 20 and 100 billion, with a B, neurons in your brain. So it's pretty packed in there. And a typical neuron will look something like this. You have a cell body, which would be here. You've got this long extension, which is an axon. And then you've got the incoming messages coming in from the other neurons up the line, coming in through dendrites. So dendrites, cell body, axon, connection to the next set of dendrites. Right? So they're interconnected, the cells. And between cells, the electricity doesn't jump the gap. So we have communication between cells, which comes from neurotransmitters. These are chemicals. They're stored in the cell. And when the electricity comes down, it releases the chemicals. They cross the gap, and they bind in the receptors on the dendrite of the next cell. So axon, electricity, chemicals, new electricity in the dendrite, and then the electricity flows through that cell, going to the end, releasing chemicals, causing electrical change in the next cell, and so on. So we have this interconnection of the cells, and these chemicals we're going to talk about later again, so that's why you're learning about it. So here, we've got a kind of an image of different neurons. So here you have the cell, you have the axon, right? And here you've got dendrites. And you see how they're all super interconnected, right? So one cell can have literally hundreds of connections. So we have somewhere close to 100 billion brain cells, and we can have tens of trillions of connections, okay? And the connections are really important because the way the electricity flows is what we think ultimately results in us being able to hear and see and think and all those things. All right, so we're going to talk a little sidebar now on the supporting organs. I mean, obviously the lung specialist would not like to think that they're a specialist supporting the neurologist, but I mean, that's just the reality of it. All the other specialists are only helping our brains stay alive. So here we go, lung specialist. So you have the lungs, and you've got these muscles, okay? So you have the diaphragm, which is underneath, and it is a big muscle. And then you've got the ribs, which are the bones and white, and then you've got the intercostal muscles, which are the red between the ribs. So the next time you go buy some pork ribs, what you're eating is this muscle. It's delicious, right? But it also serves a good purpose. It helps us to breathe, right? So that's its main purpose, I guess. So we breathe by creating suction on the syringe. So we drop the diaphragm and we suck open the rib cage, and that creates a vacuum, and in goes the air. Now, if we take a wee little tiny piece of lung and blow it up, we get this. So these are alveoli. These little balloons are where the air actually goes in and ends. So you breathe it in through the nose, it goes in through branch after branch after branch, and then at the very end you get a bubble. These bubbles are covered in circulation, in capillaries, and you see how the blood comes in blue. That's used blood, right? Oxygen goes into the bubble, and then the blue blood becomes red and then goes back up to go to the rest of the body and feed the rest of the body with oxygen. Okay, so blue blood is used, red blood is refreshed, oxygenated blood. So essentially that's what the lung does. Breathes in oxygen, gives it to the circulatory system, delivers it to the cells in the body that use the oxygen. The cells give off carbon dioxide, it goes back, fills the bubble, and then we blow it out. So oxygen in, carbon dioxide out, and muscle to breathe in. And then these balloons are kind of elastic. They're like a little bit like a balloon that you blow up, right? You blow it up and then you let go and right, the air comes back out. So we have elasticity in our lungs, which helps bring the air out. So you've got the lungs getting in the air. Now let's look at the whole circulatory system. So up here, let's pretend is the brain. So it uses up the oxygen and sends blue blood back down. Goes to the heart, goes over to the lung as blue blood. We breathe out the carbon dioxide, breathe in the oxygen. The red blood cells pick up all the oxygen, bring it to the heart, pump it up to the brain. The brain uses the oxygen, makes it blue again, and so on and so on. And of course, the blood intermixes in the heart, so some of the blood that was in the legs will end up in the brain. It doesn't really matter, but it's a loop, right? Oxygen in, carbon dioxide out. And so, of course, the pump is important, and the plumbing is important. And so this is what the plumbing looks like in the brain. You've got the carotid artery, and you've got branches and branches and branches. And so this is a special dye that was injected in a real person's brain, and you can see how there's so many branches. But the most important thing is that at the end of the day, when you get to a neuron at that level, remember there's 20 to 100 billion of these, you need a single capillary branch feeding that neuron. So the red blood cells in here are lined up individually so that oxygen goes out, carbon dioxide goes in, and then we go back to the heart, back to the lung, right? So these are tiny, tiny vessels, and if we have 20 billion neurons, we need 20 billion capillaries to feed those neurons. All right, now we're going to talk a little bit about what the brain does. So everyone, when I say memory, everyone has an idea, right? Can I remember my brother's phone number, right? That's a type of memory. It's a piece of information. It's a bunch of numbers. That's one type of memory. But really, memory is involved in all of our learning. We learn how to throw a football. It's a kind of memory. If we all decide this is going to be called green, it's depending on your memory to go, oh yeah, this thing that looks like this, we are going to call green, right? Because we could call it banana, but no, we've decided we're going to call this green. But that memory, that knowing what green means, requires memory. Next we have orientation. The thing that got us here today is orientation. 2 dimensions, time and place, right? So you all heard or found out that today, July 11th, at 3:30 p.m., I hope no one came here at 3:30 in the morning, right? 3:30 p.m., this was the place to be to hear about this topic. So it's this year, this day, this hour, right? That's time. So for us to work as a society, we need to have this thing that we call time. And it's an important part of the brain's functioning. Concentration. Oh, time and place. Sorry, place is the other thing. We all came to be here, in this room, in this building, on this street, in this city, in this province, etc. So place is, again, something that's important. I need to know where the grocery store is if my wife wants me to pick up some milk on the way home, right? So place and time are two very important dimensions. Concentration. So right now, your brain is monitoring all kinds of things. It's checking your body temperature. It's hearing me speak, but it's also hearing a fan, right? You may be seeing the pictures on the screen, you may be seeing me, but you can also see people sitting in front of you and moving. There's the cameraman, there's the people at the front desk, right? Lots of things to see, maybe some things to smell. I'm not going to comment about your neighbor, but there may be things to smell. So the brain is receiving tons of information continuously. Are you hungry? Are you tired? Is your bum sore, right? Are your shoes too tight, right? All this is continuously going to your brain. If your brain was listening to it all, there's no way you could hear me speak because all this other stuff is going on. So concentration, right, is the brain's ability to tune out the stuff that you want to tune out at this point, right? So concentration is really important. Language, of course, is the ability that we use to communicate. Language is spoken, because at the end of the day, I am blowing air at you. It's vibrating through my vocal cords, and my mouth is shaping it, and my tongue is shaping it, but I'm blowing air at you. So, but we have this convention where the way I blow this at you, you actually know what I'm saying, right? So that's language. The speaking part of it, the hearing part of it, and then, of course, the reading part of it. So, who said that was an M? Well, that's the convention. Someone decided, and we all agreed that's an M, okay? And the sound it makes is mm, right? So that's language. That's a convention. We need that for us to be able to be doing this right now, right? Visual spatial ability is exactly that. I see, and in 3 dimensions, I can do. So this is a thing I see, a little Pringles container, right? And it'll be right there, and I can reach for it, and it's because my eyes are sort of telling me you're getting close, right? And I can reach for it. So visual spatial ability. Without that, we'd be lost in space. We wouldn't be able to open doors, right? So that's visual spatial ability. Executive functioning is the thing that is the most complicated things that we do, okay? So it includes things like learning, and then learning pieces of information and pulling them together, right? Because other animals can learn things, but they can't put them together the way we can, right? So there's learning, there's making mistakes, then learning from the mistakes. There's projecting into the future, right? So, for instance, you have all heard politicians speak, and you all know that they keep their promises 100% of the time, right? We've all learned that. And so this is something where we can use the frontal part of our brain and go, right? So executive functioning is the most advanced thing that our brain does. So now where do they sit on the brain? So conveniently close to the ear is the hearing center, right here behind the ear and sort of in the around the edge of the temporal lobe and the parietal lobe. We have vision, really not practically located at the very back of the head. Our eyes are in the front, vision is in the back. Executive functioning is the frontal part of the brain. So the frontal part is the newest part of the brain. The brain sort of developed from back to front, and the bigger the frontal lobe gets, the more fancy things we can learn. Language, conveniently located near hearing. We got the visual spatial, so again, we need to see, but then we need the parietal lobe to interpret space, right? And orientation, time and place, solidly in the temporal lobe. We have other senses, so we can smell, and that's sort of centrally right up behind the nose. And last, but not at all least, is memory consolidation. So this blue thing here is called the hippocampus. It's actually part of the temporal lobe, but it's sort of in behind what we can see. So if we went up this way, straight up to my temporal lobes, we would get to the hippocampus. So they're centrally located, and they have this, that kind of a shape. All right, so we've talked a little bit about the brain, the size of it, how dense it is, how it's connected, how we feed it. What is aging? What does aging do to the brain? So, bad news. After the age of 29, on average, we lose 50,000 brain cells a day. Okay? So, we're born, we have a small number. They reproduce, they connect, and whatever. We get to 29, and then they stop reproducing, and then they start dying off. And so that means that in a year, we're going to lose about 20 million brain cells. Now, if you remember, we said we had 20 billion to start with, so you see it's only 1 in 1,000 we're losing in a year. But you can see how from the age of 20 to 90, we do lose about 10% of our brain mass simply by normal attrition. So what does that mean? So we lose some brain cells. What it means is, though, that actually, yeah, we're going to lose a little bit of function as we age. So my memory isn't as good as it was when I was 35, right? That's reality. My concentration isn't quite as good. I have harder time when there's lots of people talking in the room. I have to concentrate a little bit more to try to zoom in on the one person whose voice I really want to hear. Speed of processing, right? I'm not quite as fast at making connections as I was before. But the important thing is, all of these things don't really impact my day-to-day functioning. In fact, there's stuff I can do now that I couldn't do well at 30 because I hadn't made all the connections between different things. You know, I'd memorized the periodic table, but I hadn't sort of thought about how politics might impact my career as a physician, right? So we're still learning, we're still making connections, even though we're losing brain cells, we're still making connections. And we can age, our brain can age, but typically it doesn't affect our functioning. So what about the support systems? So we said that the lung is surrounded by muscle. That creates the suction, right? And what happens to muscle as we age? We have less of this and more of this, right? That kind of thing going on. And so we have less muscle fibers, and we have more connective tissue and a little bit more fat tissue. So what that means is that the muscle isn't as strong, right? So the breathing in part over time is going to get weaker. Means less air in. Now, what happens when you blow up a balloon, let it deflate, blow it up again, deflate, blow it up again? Is it the same shape, the little tiny skinny thing that you pulled out of the bag at the beginning? No, right? You get this little bit of flobbiness over time. It loses elasticity. Same thing in the lungs, right? After 40 million breaths, the elasticity isn't the same as it was when we were born, understandably so. So less oxygen in because the muscle isn't working as well, less oxygen out because the elasticity isn't working as well. And what about the oxygen exchange at the level of that little bubble, that little alveolus that we talked about? Well, we've been breathing in stuff for 75 years. Not all of it was good, Just by living in a city, it isn't. But if we smoke, then we're breathing in more crap, right? But so we just, that breathing in, some of that is going to stay. And you see here, right? Some of that is going to stay. Like, there's no way of getting rid of that color once it's there, because the alveoli have got this tar and this stuff in them, and they can't get rid of it. So that means, though, that the oxygen exchange at that level, at that bubble, is not going to be the same. Coughing, perfect timing. Coughing decreases as we age. That reflex, right, isn't as good. Our immune system isn't as good. So the lungs are just not keeping in shape as well as we age. Understandably, everything's getting older. Our lungs are getting older. And again, pollution, diseases of the lung, impact of tobacco, these are all bad. So, we're not breathing in as well. What about the circulation? So, the heart is a muscle. It's a pump, right? And we already talked about what happens to our muscles as we age, so the pump's not as good, right? When we climb a set of stairs when we're 20, right, almost no breathlessness. We do it when we're 85, and it's more work. Our heart is not in the same pumping capacity. So we're going to decrease the blood flow, the cardiac output. And if you look here at this artery, these little yellow dots are sort of symbolizing cholesterol deposits, right? So we've been eating a little bit too much poutine, right? And we've got the inside of our arteries starting to be a little clogged with cholesterol. What does that mean? Well, first of all, it means that these red blood cells are going to have a slower time getting through here. But it also means that when this red blood cell tries to dump its oxygen, it's got to go through another layer of stuff before it gets out to the alveolus, who's trying to get the CO2 out and the oxygen in, right? And that is plain old aging. Before we add diabetes, hypertension, elevated cholesterol, all things that are part of aging, right? But that amplify the impact of just linear aging. So, we don't breathe in oxygen as well. The pipes that are supposed to move the oxygen around the body aren't so good. The pump's failing. The brain cells are dying. I think I'll end the talk here and go home and cry. Right? So this is aging, right? Now, at the very end, if you stay to the very end, I'll give you some tricks on how to minimize the impact of aging, but this is aging. So, now we're going to talk about the changes in the brain that are beyond aging or beyond normal aging. So, before that, we're just going to do a couple of definitions. So we have basic activities of daily living, okay? These are the kinds of things we learn between the ages of, 3 and 6, let's say, right? We learn to dress, we learn to wash, we learn to bathe, we learn how to control our bladder, our bowels, right? We learn how to eat and cut food and whatever, right? So these are basic activities of daily living. That's later, maybe more when we're teenager or young adult, we learn the instrumental activities of daily living, shopping, managing medications, figuring out how to use a computer, right? Making a meal, right? These are much more complicated. These are more social. These are absolutely personal. If you don't get this right, you're in bad shape. It can be a team effort, right? So this slide is probably one of the most important slides of the day. And it tries to show, first of all, the continuum, okay, between normal aging, mild cognitive impairment, and dementia, okay? So these are states of cognitive being, okay? So what happens as we age normally? We've already talked about this. We have some mild changes in memory and maybe a little bit of executive functioning change, maybe a little bit of language change, okay? But my instrumental activities of daily living are fine. You know, so what? I go to the basement and I forget what I went for. I'm balancing my checking account. I'm managing a small business, whatever, right? It might take me a little longer to write a check. Maybe when I was 30, and now it's sort of, wait a minute, right? And it takes a little longer, but the check's written, everyone's paid, everyone's happy, it's all good, right? So a little mild change, good functioning. Now, mild cognitive impairment is an intermediate state. It's a state where if I measure your memory ability and I compare it to 100 other people of your age and your education, you're at the bottom end. Okay? Measurably, your memory is worse than your peers. Okay? But the good news is you know about this and you have tricks. So you have a little booklet that you carry with you and you write down things on your invoice for whatever, the Visa or whatever. When you write the check, you write paid on it, because you know if you don't write paid on that one, you might come back later and go, now I don't remember if I wrote a check for this bill or not, right? So you are adapting and you're okay. You got it. It's still working. So your IADLs are stable. You have a serious problem in one or maybe two domains of the brain, but you're still hanging in there. Okay? Contrast that with dementia. Dementia is the most severe form of brain disability, where now definitely more than one domain is severely impacted, but now I can't do what I used to do. Now I pay the bill, and the day after I go, oh, look, here's my bill. I need to pay it, and I pay it again. And then the day after, I will, oh, I need to pay this bill, and I'll pay it again. Because now the impairment is so bad, I forget, but I also forget that I forget, right? And now I can't manage anymore. I go shopping. I go, oh, look, Kleenex are on sale. I'll buy 2 boxes of Kleenex, bring them home, put them in the cupboard, and then tomorrow I go, oh, I'm out of milk. I'll go get some milk. Oh, look, Kleenex boxes are on sale. Why don't I get a couple of boxes of Kleenex, right? And soon I have 25 boxes of Kleenex. And of course, I don't need that many. And so now it's impacting my activities of daily living. Now, a couple of things else you notice, they're intersecting rings. And I love the Olympics, but that's not what this is about. This is about the overlap in the different conditions. There is no person that goes from having MCI, mild cognitive impairment, on July 10th to having dementia on July 11th. That's not how it works, right? It's a gradual process. So there are a couple of months when we're transitioning, things aren't great, but right? So we need to understand that it's not as clearly as you have $99 and then you have $100 and you add another digit. No, it's a gray zone. So more or less everyone starts in normal aging. At the age of 29, assuming you haven't crashed your motorcycle yet, right? You're all going to start at normal aging. Now then things are going to happen. If bad things happen to your brain, you might start moving to mild cognitive impairment. That could be that you're taking a pill that you need for something else that's hurting your brain. Now I do a memory test and I go, ooh, that's not normal. But there's a reason for it. If we take that pill away, right, we can get you back to normal, right? Now, if on the other hand, your brain has a disease that's progressive, these brain cells are dying day after day, you're going to move to mild cognitive impairment, and then you're going to continue to progress, right, and eventually hit dementia, okay? So, aging, mild cognitive impairment, dementia. It's a continuum, right? But if you see me, I will try and put you into one of these circles. I may be off because you may be in the intersection, but that's sort of my job, is to tell you where you are on this continuum. Now, classic question is, doctor, do I have Alzheimer's or do I have dementia? And what's the difference? This is the difference. Dementia is the severity of the brain damage that's affecting your ability to do stuff. Alzheimer's is a thing that can happen to your brain that can cause you to move from normal aging to mild cognitive impairment and from mild cognitive impairment to dementia. So it's the thing that causes the condition. And there are many things that can cause this, okay? So that's why this is a really important slide. So let's dig a little bit more into different definitions of dementia that you're going to hear. So for sure, dementia is what we call an umbrella term, right? Because it can be caused by this and many more other things, as you'll see in a second. But just to give you an example, Alzheimer's disease can cause dementia. Vascular disease can cause dementia. Parkinson's disease can cause dementia. Okay, so dementia is the umbrella term of the severity of the brain impairment where you've lost your function, but it can be caused by any number of conditions. So, dementia is a chronic condition. Pneumonia is an acute condition. You're fine. The next day you got a little cough. The next day you got a big fever. The next day you're lying flat in bed. You get your antibiotic. 4 days later you start feeling better. A week later it's gone. That's an acute illness. Bacteria have infected your lung. We kill the bacteria. You come back, all good. Arthritis is a chronic disease. It starts somewhere between 40 and 80. And it starts that you can't completely close your fingers one fine morning. And it takes decades, and it gets worse and worse and worse. And if it's in your knee, maybe you need a knee replacement, right? It takes decades, and you don't cure it. You do things, you decrease its evolution, you try to take away the pain, right, associated with it, but it doesn't go away. That degeneration in the joint, unfortunately, is going to continue. We can slow it down a little bit, but it's going to continue. So, dementia is a chronic condition. It starts, we believe, somewhere in the 40s, like the arthritis starts somewhere in the 40s, right? And it progresses. And sometime 70s, 80s, 60s, 50s for some really unlucky people, right? Things start changing where you actually change behavior and your ability to do things. So, chronic condition. So, chronic condition affecting memory, thinking, language, visual spatial abilities, right? Any of those 6 domains that we talked about, any one of those could be infected by a chronic condition, right? And we lose that ability. And because it's dementia, excuse me, it's reducing your ability to do things, right? It's affecting, decreasing your autonomy. Another term you will hear us use is neurodegeneration. So neuron, degeneration, right? So arthritis is a degenerative disease of the joints. Neurodegeneration is the degeneration of the neurons in the brain, right? And it's progressive, and it will get worse over time. One of the important parts of the definition of dementia, though, is that your level of consciousness is not impacted. So it's not that I'm in a coma, right, and therefore I can't answer you what the date is today. I am perfectly alert, but I can't remember what the date is today, right? So consciousness is one of the differentiating elements of dementia versus delirium, for instance, where delirium is an acute illness of the brain, and I'm confused. It's just because everything's sort of short-circuited. but my level of consciousness is affected. Like I may be sleeping heavily or I'll be hyper alert. So let's talk a little bit about dementia by the numbers. So 2015-ish, we had 500,000 people across Canada with dementia. Okay? And by 2030, we expect to be almost at 1 million. Okay? So it's definitely going up. In fact, if we think about age, chronological age, when we're at 65, we have about a 1 in 40 chance of having it. That doubles every 5 years, so that by the time you're 85, it's sort of around 1 in 4 chances, 1 in 3 chances of having dementia at the age of 85. So it puts things into context, right? So 65,000 new cases a year, and 2/3 of people diagnosed with dementia are women. And beyond that, dementia affects women more than men simply because of their typical caregiving role. So the wife of a man with dementia is going to be doing the caregiving. The daughter of the woman with dementia will be doing the caregiving. So women are multiple times more impacted by dementia in our society than men are. By the disease directly, but also indirectly through the caregiving role. So it's a very significant disease. And they say that 3 out of 4 Canadians know someone living with dementia. So a neighbor's grandfather, or your coworker's mother, right? Most people now know someone affected by the disease. So, dementia, loss of cognitive function, affecting my ability to do things. What's it caused by? 2 groups of things, right? We're talking about the brain cells. The cells themselves can get sick and die, and that would be bad. They're already dying by age, but having more of them die because of something else is bad, right? This is the list of some of the things that can happen inside the cell. So Alzheimer's disease is a disease of a description of a change of the cells that makes them die faster and in a particular pattern. Frontal temporal dementia, same thing. Lewy body disease, Parkinson's disease, posterior cortical atrophy. All of them are things that happen inside the cell that causes them to get sick and die. Okay? Now, we can take a perfectly healthy brain cell and kill it, right? And one of the ways of doing that is to cut off the oxygen flow, right? That's what happens when we choke someone and they pass out, right? We've cut off the oxygen to the brain. Now think about doing that chronically, not acutely, chronically over decades. And you can see how we can starve the brain of oxygen. Vascular disease. We can increase the pressure in the brain, block some of the outflow of the spinal fluid, and the pressure builds up in the brain. If there's fluid building up in the brain, it means that the actual brain itself is getting squished. We can squish the brain cells to death, right? So, outside factors that can hurt the brain. What about boxers, right? You hit the head 100 times every weekend, right? That can't be good. You're going to kill brain cells. It's going to accumulate over time. These brain cells are going to die faster than normal aging. It can cause dementia. Metabolic toxins. A glass of wine, my liver can handle it. 2 glasses of wine, probably. 5 glasses of wine, 2 bottles of wine, not so much. That alcohol is going to go straight to my brain and it's going to hurt my brain cells, right? If I do it enough, not once, but if I do it enough, I will poison my brain. It will kill the brain cells. It will be a type of dementia, right? So that's why dementia, it's that end stage, the worst damage affecting my ability to do things, and I can do it by the outside. Infection, another cause, an acute traumatic brain injury, right? So a car crash or whatever. All right, dementia, the causes of dementia shift as we age, so that when you're under 65, Alzheimer's disease and vascular dementia are about half of the causes. Frontotemporal, alcohol, Lewy body, and all the others make up the other half. Look what happens as we age. Alzheimer's is still only about a third of cases. Here. There's another third that's Alzheimer's plus something else. Right now we're getting older, we're accumulating stuff, right? Vascular dementia is now almost a third. So you've got almost all accounted for between vascular and Alzheimer's disease and mixed dementia. You've got almost everything accounted for at that age. So when we see younger patients, we have to think about it differently than when we see older patients. What about genes? What about genetics, right? So I always get from the family, okay, my mother has Alzheimer's, my aunt has Alzheimer's, what are my chances of getting Alzheimer's? So the statistical answer is that only about 1% of real Alzheimer's cases are familial, where the father will have it, the daughter will have it, the grandson will have it, right? It goes, you genetically transmit it. It's exceedingly rare, 1%. Those families are known. They're known because of research, but they're also known because the family knows, right? So the random person that comes to my clinic is more likely to be in the sporadic category. Vascular dementia is more complicated. If all of my family members died from heart attacks and strokes, it means that genetically our plumbing is bad, right? So my chances of getting bad plumbing are also high, right? But it could be that there's absolutely no heart disease in my family, no strokes in my family, but I'm smoking 2 packs a day for 50 years. I can plug my arteries all by myself, right? I don't need bad genes to do that. So lifestyle is going to mess up sort of our genetic thing. If I only eat poutine, I'm going to be in here too, right? And by the way, I like poutine for that. I don't want to be quoted as being anti-poutine, not at all, within reason. Frontotemporal dementia, now we start getting a little bit more of a mix. So frontotemporal is more likely to have a familial component. Lewy body, rarely. Parkinson's disease, not a lot. And Huntington's disease, on the other hand, is 100% familial. It doesn't sort of spontaneously happen. If it's in your family, you have a chance of getting it, period. Okay, so now we're going to get into the functional part of the brain. So we're born, and depending on where in the world we're born, we're going to learn a completely different language. We have the ability to learn language, but we don't know what language we're going to learn. So it's like nothing. The capability is there, but there's nothing, right? We learn to see things. The first thing we learn is that our eyes start recognizing round versus not round, and round is good because that feeds us. That's our mom, right, usually, or dad, right? So round is good, and all of the shapes are irrelevant, right? So we learn, and we develop. So the first thing we learn is to hold up our head. We learn to pay attention, to ignore the noise. We learn single words, right? Mama, whatever, dada, right? Start simply. Then we learn to sit up. Then we learn to stand up. Then we take our first few steps, right? And everyone hears about it because. Then we learn to follow single instructions. Put the teddy in the bed, right? We can do that. 5 instructions, do this, then that, then no, that's not going to work, right? One thing at a time. We learn to use a spoon. We hold it, and the first time the peas are all over the place, but eventually, right, we can get that spoon into our mouth. We understand more, our vocabulary grows, we learn to brush our teeth, we dress, we become continent, right? And don't need those pull-ups anymore. We learn fine motor skills, right? Now we can do very tiny things. We learn to make bows for our shoes, right? We learn sentences now. We can do 3 or 4 words, 5 to 6 words, right? And we can name people. It's not just boy and girl. Now it's Tommy and Susan, right? And our concentration gets better. Now we can do the same thing for more than 2 minutes at a time. Now we can read a whole book. Lots of pictures, but little sentences, but we can do the whole thing. We sit still for half an hour for one book, right? And if we use mathematics as an example, first we learn to count. 1, 2, 3, 4, 5, right? Then we learn to add. 2 and 2 makes 4. Then we go multiply groups of 2. 2 times 3 is going to make 6, right? So we build on that skill, that mathematical skill. Eventually, we learn to balance a checkbook. We have money coming in, we add that together. We have money going out, we subtract that, add it together, and then subtract it from the whole, and we come up with a new balance, right? That's complicated. But we learn it from 1, 2, 3, 4, 5, and we build it. So it's the onion. We start with a core, we add a layer, we add another layer that depends on that layer, because if I'm learning English, don't count to me in French. Well, we can do that, but I mean, it's like it's got to build on the foundation. We balance the checkbook, and finally I manage a budget of $60,000 at home, mortgages in there, taxes, you know, whatever. That's normal learning. We're growing our onion. Dementia is essentially the unlearning of what we've learned, right? So the first thing is, I can't manage that budget anymore. I can't plan for taxes. I can't, the math isn't working out, and I forget too many things, right? It's breaking down. Eventually, I can't even balance the checking account. Adding and just even change for 5 is hard, right? My concentration goes, I can't read a book, because I can't even remember what happened in the last chapter, much less the first chapter of the book. My sentences get shorter and shorter, more and more concrete. And why? Because the brain cells are dying. All those connections I made all through my life, they're unraveling, right? I'm unlearning. And eventually, we can't do anything anymore. So, Alzheimer's disease, this is what it looks like in pathology. So on the left, you have a nice, plump, healthy, maybe 29-year-old brain. On the right, we have much more reduced in volume, lot more space, right? There's big gaps between like little valleys between the different parts of the brain. And the whole brain is affected. So this is severe Alzheimer's disease. So this is a cross section. So if you cut it like this, right, you get this view, and you see you've got little places where the spinal fluid flows, and then look what happens when the brain starts atrophying. The ventricles get huge, right, because they're just filling void. Okay, so Alzheimer's disease, everyone's heard about amyloid plaques and neurofibrillary tangles. What does that all mean? This is the answer to that question. So normal neurons, they have a nice shape. Between them, there's no mess, right? And this is what Alois Alzheimer described in 1907 or whenever it was that he published his first paper. You've got these plaques, and then you've got these funny things inside the cells that don't look quite right, neurofibrillary tangles. These microtubules are part of the structure of the cell, but they also transport things from one end of the cell to the other. So when that falls apart, the cell starts losing its shape, loses its function, ultimately it dies. These plaques are outside the cells. Stuff that the cells produce accumulate and make these plaques. So tau protein is the one that's inside the cells causing these tangles, or as part of these tangles. Amyloid beta protein collects outside the cells and clumps into these amyloid plaques. So when we take the brain of someone that has what we call pathological Alzheimer's disease, we will see cells that are shriveling in this manner with the neurofibrillary tangles, and we will see these plaques, and we can count them, and there's sort of counting the number of plaques as part of the diagnosis of a pathology for Alzheimer's disease. Alzheimer's disease starts in the hippocampus, the memory part of the brain. It's on the inside of the temporal lobe, right? Like I said, sort of up in here. And at the beginning, it can affect a little bit the frontal lobe. It starts to spill over a little bit here, and everyone knows what we said, that this was memory here in the hippocampus, and here we have the beginnings of executive functioning. So my planning isn't so good, right? I'm starting to have difficulty with that $60,000 household budget, right? Next, we see it's getting darker, and it's following this way, going this way along the temporal lobe. What else does the temporal lobe do? My sense of time and my sense of place, right? Now I can get lost. Now I don't remember the date, so I actually don't congratulate my daughter on her birthday, right? And eventually, the disease is sort of everywhere, and now in addition to those little things that happen to my individual cognitive functions, now I can't take care of myself anymore because personal care is too difficult, right? So that unlearning, I'm back to the 3-year-old, right? Except I've gone the other way, right? But that's sort of where I'm back at. Okay, so this is just showing us the progression again from mild cognitive impairment, mild Alzheimer's, moderate and severe, and obviously more and more things go wrong. At the end, we don't recognize ourselves, we don't recognize our family ones, our loved ones, and that kind of thing. All right, so management of Alzheimer's disease. When brain cells die, they're not producing neurotransmitters. They're not communicating with each other as well. If they're not communicating, the next cell isn't going to get lit up, and it doesn't know the message that it's supposed to be getting, right? So a good place to start for the treatment of dementia is to see if we can increase the amount of acetylcholine available to the brain. So we created these, not me, but we as a society created these acetylcholinesterase inhibitors. They increase the amount of neurotransmitter of the acetylcholine type that the brain has available to it. The brain is going to produce less because of the dementia, the neurodegeneration, right? But this is going to help more of it be available. Does it fix the problem? No. These cells are dying, and they will continue to die. But we're going to trick the brain into thinking there's more communication possible than is actually available. So what medications are these? There's 3 of them: donepezil, rivastigmine, and galantamine. And the donepezil was first first used in 1996. Rivastigmine quickly followed, and then galantamine was last. And the reason I have the daffodil up here is because galantamine is actually a derivative of the daffodil. And for those that are Egyptian studiers, they would know that the pharaohs actually knew about the power of the daffodil bulb to enhance cognition. So there you go, a little bit of history involved for free at no extra cost today. That's the galantamine. The last that was discovered was the rivastigmine, 2007. They developed a patch, and that's the last development in the drug world for dementia, 2007. Now, every good medication has some unfortunate side effects. Acetylcholine is available in the brain. That's where it works mainly. That's where you want to stimulate the brain. There's also acetylcholine in the gut and in the bladder and in the heart. So in the gut, you have a 1 of 8 chance of stimulating the gut, causing nausea, bloating, diarrhea. Okay? You have a 1 in 8 chance of increasing the frequency you have to go to the bathroom to urinate. Okay? So this may not be an issue. If you're healthy and your brain is getting stimulated, you may be willing to pay this price. But if your ability to go shopping is now impaired because you have continuous diarrhea, you're not getting the social stimulation you need, and the quality of your life will go down dramatically. We need to think seriously about the risk and benefit of every medication we use, right? So just not to forget, this is real. 1 in 100 chance of getting a cardiac arrhythmia, where we actually slow the rate of the heart, and that can make you dizzy. Dizziness can make you fall. Falls can break your hip. If you're 85 and above, 1 year, you have a 50% chance of surviving the year after a hip fracture. So it's not trivial. These are not trivial. They're good when they help, but we have to be honest when we talk about these medications. Memantine is the only other medication that's technically approved for treatment of dementia. Kind of a weird medication. In 1968, it was designed to treat diabetes. In 1980, we found, oh, look, it sticks to the brain for some reason. And then we sort of grew some brain cells, and we said, well, I wonder what happens if you add memantine, and we found that they seem to live longer. And we said, hey, dementia is when the brain cells are dying. Maybe if we give the brain some memantine, we can keep the brain cells around longer. But unfortunately, it hasn't been as successful as we had hoped. Okay, people are hearing the thunder, and they're not concentrating on me speaking. So good. Because the good news is it doesn't have a lot of side effects, so it's pretty safe. I don't think I've ever had to stop it because of side effects. I've just stopped it because it hasn't done anything most of the time, so unfortunately. So the government does not pay for it in Ontario because they say it's useless, right? We don't pay for water, we're not going to pay for memantine. Now, like in any chronic disease, like I said, we can also treat the symptoms, right? So if someone with dementia is affecting their temporal lobe and now they're forgetting what's day and what's night or getting mixed up, right? We can help them resynchronize their clock by helping them sleep at night. So there are good sleeping pills like trazodone and mirtazapine that can help, at least so that we make sure that everyone sleeps at the same time, because there's nothing more disruptive to a caregiver than being up with them all day and then being up with them all night, right? When do we get to recharge our batteries, right? So we do that. Sleep, depression. At the very beginning stages of dementia, we're actually going to notice that something's off, right? We may not be able to put our finger on it exactly, but we're going, the world is just wacko, because like my daughter is telling me, she told me this yesterday, and she never told me that yesterday. Like, people are saying things that just don't make any sense, right? So we're going to be anxious. We're going to be depressed. We're going to say, like, this is not what I signed up for, right? So treating the depression can be helpful, and there are good antidepressants to use in dementia. There are also very bad antidepressants to use that we don't use in dementia, right? So again, that's why we have people who know this, and they're the ones we should trust on this, right? To make sure that we get good medications, not bad medications. At the very end stages of dementia, we can get agitation, we can get hallucinations, we can get paranoia, we can get physically aggressive, right? So in those cases, we might actually need an antipsychotic, and there are antipsychotics we can use, and they're not great long-term, but they do make a difference short-term. And again, if we're very honest about what we're doing, we're trying to get good quality of life for the next couple of months, even if we know at the other end we may be shortening life by a couple of months. Do we want, 6 months of horror, or do we want 5 months of relatively better quality of living, right, for everyone? So as long as we know what we're doing, we can have that conversation and we can decide what we're going to do. So that was the long story on Alzheimer's disease. Now we're going to get to the other types of dementia. We're going to go very quickly through them because it's the same story more or less, except they look differently, right? So here you see a little white plaque There's another one, little ones here and there. So, right, so you can see sort of it's a little bit speckled, a little bit maybe like a Swiss cheese kind of in picture, but little flecks around the place. So those are vascular changes, and that's because the circulation to those specific parts of the brain have been poor, partially blocked, maybe smoker, maybe diabetes, right? It doesn't matter the why, but the circulation is partially blocked, and so not as much oxygen is getting to those parts. Those are dying cells, right? Those are cells that are dying or are dead already, and that changes the density of the brain. So we can have a stroke, right? We can have a stroke. It clots a major artery. Right here, this artery is clogged. There is no oxygen getting to this part of the brain from that artery. Luckily, these other guys are helping out a little bit, but there is a part of the brain that is absolutely getting zero oxygen from that. It will die. It will turn to water. There will be no living cells there. We will have a bubble, a water bubble in the brain. That's what a stroke is, okay? So if a stroke is massive enough, like we can have a stroke that takes out a chunk of the brain, obviously that's going to affect our cognition. We will go from relatively good functioning to bam, right? After a stroke, we can't speak, we can't do things, right? So that's one type of dementia caused by circulation problems. Now you can also imagine, right, that you have just wee little bits of change here and there, but just over the decades, we're going to still soften out this part of the brain anyways. It's not that all of a sudden, bam, we have a plug, but we've been plugging all the little vessels gradually over time, and now they're still getting the same effect, but very slowly and gradually. So we can have, that's more like this subcortical kind of dementia. Sorry, and this one is after a stroke. We're not sure why in some cases after a stroke, years later, things start to go downhill again, and we're not sure if it's part of the stroke syndrome itself or if it's simply because the stroke happened in a particular context, high blood pressure, diabetes, whatever, and we can't get rid of them 100%, and so we're still going to have some progression, or is there actually something to do with the stroke and how it evolves over time where further cognitive decline can happen? So this post-stroke dementia is still a bit of a mystery as to what it is. So what does it look like? Alzheimer's, as you saw, like the brain just gradually gets darker and darker blue as we get that progression of the change. Here, because we have the circulation impacted, it might be that nothing much happens for a little bit, and then whoops, we get a little clot, and boom, we lose a little bit. And then it might be stable a little longer, and then boom, we lose another bit, right? So it can be more stepwise because we have stability and then we lose a little bit. The other thing is we can have fluctuations. So think of a hose, right? A garden hose that's got a kink in it. If we turn on the tap a wee little bit, nothing is going to come out the other end. If we open the tap full blast, we're going to increase the pressure, the kink will straighten out, and the waters are going to come out on the other side. So imagine in your brain, your heart, you're lying, you're sitting watching TV for a day, your heart has to do no work. It's not going to make enough pressure to open that garden hose kink, right? On the other hand, today, I have to go shopping, I'm going to walk to the store, I walk around the store, I walk back home. I've created a lot of pressure because my legs are asking for oxygen, my heart's pumping hard. Now, more oxygen is getting to the brain because all those little vessels are getting filled up with pressure, and boom, now I'm getting better oxygen. So on that day, people go, oh, today she's pretty good, right? The other day, not so much. So we can have fluctuations day to day because of depending on how that circulation is going on any particular day. That's not the case for Alzheimer's, pure Alzheimer's, where every day we lose a handful of more cells and more cells and more cells. So it's going to be much more steady decline, right? The challenge in vascular dementia, of course, is I don't know what part of the brain is going to be affected, right? It could be the language part of my brain. It could be the memory part of my brain. It could be the mobility part of my brain, right? So the sequence isn't a given. In Alzheimer's disease, it starts in the hippocampus, it goes to the frontal part of the brain, it spans out and hits the language and comes around and it'll affect my ability, right? It's got a pattern. Vascular, the pattern is, depending on how my brain circulation is, it's going to hit here, it's going to hit there. So if you see someone like me and I go, I don't know what it is because it's not following a pattern, it's true. I don't. Vascular comes to mind as a possibility because vascular is sort of the big question mark. Whatever, it could be vascular, but it could be any particular pattern. The only thing that's pretty steady is that the vasculars will have that slower cognition. Why? Because cells are dying more quickly sort of in different places in the brain, and so the communication between different parts of the brain is going to be slowed. I sort of give the example of driving to work, right? If I drive to work at 4 in the morning, right, it takes me about a half an hour. If I drive to work at 7:30 and there's been an accident, right, it's going to take 45 minutes. If there's an accident and construction, it's going to take me an hour and 10 minutes. So the more blockages, the more dead cells, the more construction sites, right, the more detours my thinking has to make, the slower my thinking is going to be, right? So the slowed cognition is kind of classic. The other thing is when language is affected in vascular people, they're more likely to be aware of it. And I'll say, man, it takes me forever to name my grandson, right? The person with Alzheimer's doesn't remember that that happened because they can't, because their memory is the first thing that goes. Here, memory is just part of the puzzle, and they're much more aware of their changes. They're also more likely to have depression. We're not sure why that is. Is it because, you know, the mood centers of the brain are also suffering from these vascular changes? We're not sure. Or is it the subcortical nature of the damage? We're not sure, but definitely an increased risk of having depression. You sort of have the happy, demented Alzheimer's person because they're happy because they have no worries, because they don't remember anything bad that ever happened. Who's Donald Trump, right? Why would I be worried? Why would I be upset? Life is good, right? The rest of us, we have to suffer with the reality of listening to him again, or another tweet. I'm not that I'm political in any way. So, vascular dementia. Now, frontal temporal dementia, big surprise, right? Healthy brain, shrunk brain, shrunk brain. Frontal temporal dementia, right? And what does the frontal part of the brain do? Executive functioning. What does the temporal part of the brain do? Amongst other things, language, right? So, not surprisingly, there are two main subgroups of frontal temporal dementia, the frontal subgroup and the temporal subgroup. The frontal subgroup is going to have changes in behavior, right? So you guys today decided, I want to learn something. I'm going to go to the Alzheimer's or Dementia Society session on whatever. So you had motivation. You didn't have to come, right? You sort of, I'm going to do this. Someone who has frontal damage, right? They're not going to have that initiation. They're more apathetic. You have to grab them and drag them to places more likely. Other thing is disinhibition, right? So when I'm walking in the street and I see something funny, I might feel like saying, oh, that's the stupidest hairdo I've ever seen, right? But I'm not going to say it because I know I might hurt someone's feelings or it's not socially appropriate, right? Person with frontal temporal dementia, that filter is gone. So I see it, I think it, I say it. Boom, right? So this is really disturbing to the family, right? That goes to the restaurant and the person's commenting about people's appearances or saying, this sandwich is soggy, like, oh my gosh, right? So it's everyone might agree, but that's not the point, right? That we lose that filter, that frontal executive functioning. We overeat, right? There's a cake there. Looks pretty good. I'll have a slice. Oh, it's really good. I'll eat the rest of the cake, right? Because I can't control, I don't have that, hey, whoa, there's like 5,000 calories in this cake, right? Is that the best thing for me right now? Maybe not, right? So that control again. Planning, judgment, those are the types of things that we have with frontotemporal dementia. On the temporal side, like I said, we have language. That's the biggest issue. And the first is a progressive non-fluent aphasia. It's a type of disease where we forget the words, okay? At some point, we have 20,000 word vocabulary. We go down to 15, and we go down to 10,000 words. So it means that I want to talk about this thing that you use to advance the slides, or that, do you have those things that open the door when it's locked, right? So I can't think of the word, but I can describe it, but I also know that this is a problem because I'm in the middle of my sentence. I want to say, I ran out of the house and I forgot my, those things that you got to use to open the door, right? So the story stalls, right? It skips. It's not smooth, so it's non-fluent. In contrast to semantic dementia. Semantic dementia is I lose the meaning of words, right? So I know that there are people who have small furry animals in their house. Some of them we call dogs, some of them we call cats. I don't remember which one's which though. And the thing is, it's not that I don't know, it's that they get switched and I don't even notice. So I'm going to go to the park and I'm going to walk my cat. Good luck with that. Then, a couple of months later, I'm going to go walk on the lake. I'm going to walk my cat on the lake, right? Because now it's the dog and cat are mixed, but it's also the lake and the park are mixed. And at some point, I don't understand anything because I can't make the connections between the words these people are giving me. They're perfectly fluent because they're just substituting the wrong word, but it's fluent. They're telling me a story, it's amazing, and they love it, and they're having a good time. I have no idea what they're saying. Or they'll write me a letter, and I have great examples of it, patients that have written me letters. I have absolutely no idea what they're saying. It's English, but none of the words work together, right? Because the semantic, the meaning of the words are mixed up. So two groups of frontotemporal dementia, and then two types of language problems. Next, we're going to talk about Lewy body dementia. So just like Alzheimer's disease was first described by Dr. Alzheimer, Lewy body disease was first described by Dr. Lewy, and it was these funny little bubbles that seem to appear in certain types of cells. And what's typical about Lewy body dementia is really these visual hallucinations. Now, hallucinations can be really frightening, right? Schizophrenic that sees God or whatever, like that's horrible, and they need to be treated acutely with antipsychotics because, right, terrible things can happen. These hallucinations are different. It's like the bunny in the house. Now, we have bunnies in our house, but that's a different story. These are people that don't have bunnies in their house, and they go, yeah, there's this rabbit that keeps popping through the living room. Does your daughter see it? No, I don't know. She's never around at the right time, right? Does it frighten you? No. It's kind of silly, but yeah, it's a bunny in the house, right? So it's not frightening. And so, the family goes, what can you do about the hallucinations? And the honest truth is I say, you know what? It's not there. It's not disturbing her or him in any particular way. Let's just leave it. Let's just know that there's a, rewiring that happened, the bad wiring in the back of the brain, the visual cortex, right? There's something going on. And let's just leave it if we can. And only if it gets really disruptive do we try something about it. Parkinsonism. So Parkinsonism means some of the symptoms of Parkinson's disease. So people with Lewy body dementia do not have a resting tremor. The classic Parkinson's tremor, right? They don't have it. They do have sort of eventually the sort of sticky, small shuffling kind of gait, the curved posture. So we call that Parkinsonism. REM sleep disorder is another pretty clear hallmark of Lewy body disease. So you or I, when we dream, we actually don't move. The body, in its evolution over the last 20,000 years, right, has noticed that if we dream that we're running and we start running in the middle of the night, we're going to hurt ourselves. So it says, okay, whenever I send a dream, I'm going to paralyze the body and we'll be fine, right? So we lie there in bed and go, and we dream and our eyes are flipping and flopping, but we're not moving. That's good because we're safe. People with REM sleep disorder, they actually do move. So the spouse of the person with REM sleep disorder will wake up with bruises because when they talk to someone and swing their arm out, right, they actually swing out their arm when they're dreaming. So REM sleep disorder, classic thing to look for in this disease. Visual spatial difficulties make sense, right? The back of the brain, the visual is miswired, so that's difficult. So doing things becomes harder. It's more fluctuating as well. So now you can see how different types of dementia are starting to cross over, right? It used to be that we had Alzheimer's, nice and smooth, vascular, kind of bumpy. Oh, now we have another bumpy one. Great, right? So it gets complicated, and that's why, you know, it takes us sometimes time to come out with the best diagnosis. Yeah, we'll move on. Parkinson's disease, so it's a disease that starts in the substantia nigra part of the brain, and it controls fine movement. And that resting tremor is number one, pretty much 100% of the time. It develops, and eventually I will get that posture and I will freeze. Eventually, my brain will be impacted and I will not be able to do executive functioning. I won't be able to make decisions. I won't be able to make plans, usually a little later on in the disease. And so, yeah, so anywhere from 50 to 80% of people with Parkinson's will get dementia at the end. So Lewy body disease and Parkinson's disease are like cousins, okay? They have a lot of common features, but they start in different places. Lewy body dementia, I start with hallucinations, visual spatial difficulties, and eventually I get my Parkinson's shuffle. Parkinson's, I start with movement issues, my shuffle, and later my brain starts doing difficulties, having difficulties with the reasoning and judgment, that kind of thing. Then, just to add more fun to it, there is a Parkinson's plus syndrome, which actually includes multiple diseases, and these have many of the Parkinson's traits as well, plus language, plus executive functioning, and sometimes depression. So this slide I'm not going to spend a lot of time on. If you want to look at it at home, great. But essentially it tries to differentiate how we manage the different conditions. Alzheimer's disease, definitely worth trying a cholinesterase inhibitor if there's not too many other medical complications and mobility issues, because diarrhea with no mobility is a bigger problem, right? And treat the symptoms like sleep and whatever. Vascular dementia, definitely worth trying a cholinesterase inhibitor as well. Treat the depression as needed. Frontal temporal, cholinesterase inhibitors typically aren't very helpful. There is one subtype of language that seems to be frontal temporal and yet have characteristics of Alzheimer's changes. That one might respond. Treat the behavior, because of course these are the frontal side of things. These behaviors are challenging. Doesn't fix the disease, but if we can take the edge off the behavior, maybe we can go to the restaurant once in a while and not, right, have to stay home. Lewy body, try rivastigmine. Some people try others. Rivastigmine I find is sort of the most effective. The REM sleep disorder, we do have medications to reduce the amount of whacking during our dreaming. Any kind of psychological changes, again, we manage, and we have to avoid antipsychotics. They react terribly to antipsychotics. So someone who has a hallucination, the doctor goes, oh, here, have an antipsychotic, bad. We get bad results. They end up in the hospital. So, and then we can consider Parkinson's meds. Obviously in Parkinson's, we treat the Parkinson's first, consider a memory aid. Some cases, if there is a dual diagnosis, they might respond to the cholinesterase inhibitor. And the Parkinson's Plus, the same thing. Consider Parkinson's medications, not often successful, an antidepressant if you need it. As if that all isn't complicated enough, in fact, in reality, we, as you saw on that slide with the pie graph, right, we actually probably have more dual diagnosis cases of dementia than we've thought in the past. So, as if it's not hard enough to sort of figure out, is this sort of the classic Alzheimer's pattern advancing, or is it sort of the stepwise off vascular pattern happening, or is this Lewy body because we got some funny kind of hallucinations? It could be both or all three, right? So that makes the pattern recognition really messy, right? Because vascular can be anywhere. So if you have a little bit of memory and then something off in left field, maybe it's Alzheimer's developing with a vascular thing affecting language, right? So it's mixed dementia isn't a cop-out. It is probably real. It's probably real more often than we think. And actually in pathology, when we've done multiple stainings of brains, we have found that there were more times multiple pathologies than were diagnosed by physicians. So just to touch delirium very quickly, delirium is an acute disease of the brain. And we have a change in our arousal state. So either we're in a coma, the brain is just not working, or it's hyper-aroused and we're like all over the place, we're running up and down the halls and we're screaming and whatever, right? So it could be hyper-aroused as well. So we have a change in that arousal state. And we have all these possible causes of delirium. You're way more likely to end up in the emergency room with the delirium than you are with dementia, right? Dementia gradually progresses month after month after month. Delirium is like, bam, big change. And like everyone's going like, whoa, like what do we do with this? They need to be treated acutely. This is an acute illness that needs to be treated acutely. The diagnosis has to be made quickly, and we need to do as best as we can. Often, most of the time, when we have a delirium, it suggests that there's already something going on in our brain, and we're more likely to have dementia in the near future, simply because having a delirium sort of out of the blue with no other underlying brain issues is more unusual. Can we drink enough to go into delirium? Sure. But then we know because there's 14 empty bottles, right? But responding badly to a little bit of alcohol and a little bit of pneumonia, and now we're like completely in a different state, there's probably some underlying problem. Depression is the other one. So you can imagine, if I'm so depressed, I stop eating. First, I stop making meals, but I'm stopping making meals because I don't want to eat anyways. I'm going to stay in bed most of the day. I'm not going to shower, right? If you do a memory test with me, I'm going to go, right? Why would I be interested in doing this, right? So I'm not going to do well on a memory test. It looks like I can't do anything anymore. I'm not showering, I'm not dressing, I'm not eating. So it looks like dementia, right? It can look like dementia, but it came on real fast, right? A depression is much faster than 20 years of developing dementia, right? So it's faster to come on, and you've got that sort of loss of interest. And we can have apathy with the frontal, right? But it's a little bit different, and the blinds are down, and it looks differently when you dig deep. So complicated, of course. Like I said, if you have early signs of dementia and you're aware of them, you're going to be depressed or anxious or both, right? So it may be that you have an underlying brain disease which is causing you to be depressed or anxious. We treat it, the memory may not come back completely, but at least we've taken care of the noise, right, to make sure that we really have a clean picture the next time I do your memory test. So I will send people back and say, look, I'm worried, but for now, let's just make sure we get a clean picture of your brain function at its best. So let's try and treat the depression. Let's try and treat the anxiety, give you the fighting chance, and then we'll see what your brain function is actually, right? And there is a small subgroup of people where we think that chronic depression will convert to dementia. Like chronic depression, meaning you start being depressed in your 30s, right? Just like chronic arthritis starts in your, right? Chronic depression starting in the 30s, it may be that there's a subgroup of those that do develop dementia in their 70s. Yeah, let's move on. This is for medical students, the 3 Ds, dementia, delirium, and depression. This they have to memorize for the exam. You don't need to, but you know, one of the things we need to do is differentiate them. That's my job, right? So you guys come and see me and we'll talk about that. So let's do an example of a clinical case, right? So here's a 77-year-old lady. She goes to the basement, she forgets why she went there. So far, it's the same as me. She's not worried, but her family is. Now, that's a little different. Now, my family's worried about me too, but that's not the whole of the story. But so it's not about my memory, right? So the family's worried about her memory. Now, we're starting to see that she's not remembering all the things she's forgetting. They do, right? They come in with a list of all the things she's forgotten, right? So they know she's forgetting. She's got less, she's forgetting that she's forgetting. It's progressed gradually, certainly faster than her peers. So other 77-year-old ladies in her bridge club don't want to be her partner anymore, right? Because she doesn't get the rules as well anymore. She's having difficulty paying her bills, right? Now we've crossed over from mild cognitive impairment into dementia, right? Functionally, there's a change. Sometimes she buys things she doesn't need. Her husband is doing more and more of the day-to-day activities. Her aunt had dementia. There's no vascular disease in the family. Socially, there's nothing particular. Mild arthritis, she had a hysterectomy, memory problems, her sense of time is a little off. She's having a little bit of word-finding difficulties. And guess what? When you test it, you see it. 23 on 30 on the MMSE. That's bad, right? Nothing unexpected or nothing asymmetrical on the neurological exam, because now we're looking for Parkinson's plus stuff, right? That kind of thing. And we do lab tests and there's nothing. She's not missing any vitamins. Her TSH isn't off, right? Her CT shows mild atrophy. Okay, she's 77. Like, she's not going to have a 27-year-old brain. We know that. Now, she's on Tylenol, which is good for her arthritis, but she's on amitriptyline for sleep, okay? Bad. Amitriptyline is a anticholinergic drug. We said acetylcholine is the memory neurotransmitter. You give a medication that sucks the acetylcholine out of the brain, what do you think is going to happen? Their memory is not going to be better. It's going to be worse, right? So bad, right? So like I said before, there are antidepressants or sleeping medications that are bad for the brain. That's our job, right, to help you sort through that. But in this case, amitriptyline, a big no-no. So what do? We have a diagnosis, right? She doesn't have any vascular things going on. She doesn't show anything weird on the neurological exam. She's not hallucinating, right? And it started with memory, and now it's starting to do a little bit of executive functioning, a little bit of language, a little bit of orientation to time. Sounds like pretty straightforward Alzheimer's disease, right? We're going to wean the amitriptyline. Her brain has had this amitriptyline now for many years. We can't just stop it. Even though we know it's bad, we can't just stop it. We have to go gradually. Now, she's going to have rebound wide awakeness at night. So we're going to have to replace it by something else. Remember, we said trazodone is one of those things that's actually a good replacement because it doesn't affect acetylcholine. It helps you sleep without the bad side effects. So we're going to have to do that gradually. We're going to consider it an episode. We're going to consider it. Why? Because maybe her mobility isn't good. We didn't talk about that, but if her mobility is really bad and we give her diarrhea, it's going to be a disaster, right? So we still need to think about, right, the cholinesterase inhibitor. If she's otherwise fine and she's 77, why not give it a try? If we have bad side effects, we can always discontinue it at that time. But, so we'll definitely consider it. Now, for her, she started it, and guess what? The first 2 days, she was nauseous. Yeah, that's what it does. It's a cholinesterase inhibitor. It's increasing the amount of acetylcholine, including in the gut. And the gut's going, woohoo, I can contract, but the food doesn't know where to go, right? Do I go up? Do I go down? So I'm going to be nauseous. But it's only for 2 days, because then my body goes, okay, this is the new normal. Fine, we'll deal with it, right? And then we're okay. So we're going to monitor her cognition over time, because this is a disease of many years. So we're going to see you in follow-up. We're going to do this together. You're going to tell me where I could help you the most. I'm going to tell you, if I can help you with that, what to expect in the next little while to make sure we're all prepared, we're on the same page, we're paddling the canoe in the same direction, right? That's, at the end of the day, the best we can do in this case. Future planning. Okay, not too bad. We're still on track. Let's talk about research. So, there are a number of reasons why we have not had any new medication since 2007. And even the one in 2007 wasn't really new, it was just a new way of packaging it. And that's because of a number of things. The first is, if the disease starts at 40-something, because it's a chronic disease like my arthritis, right? And then sometime when I'm 77, I start having problems with my memory enough that I buy things in duplicate. At 77, it's kind of too late, because we've been accumulating stuff for 30 years, right? So if we're having changes in the brain way before the symptoms appear, it's going to mean that our treatments are going to be a bit late and might not solve the whole issue. So that's a real important issue. The next thing is that sometimes we can't diagnose because we're still waiting for it to evolve and the symptoms to become more clear. Sometimes we will never have the diagnosis, because I can't take a slice out of your brain and look at it under a microscope. I have to go with your symptoms and indirect evidence. And if we don't do an autopsy, we'll never know what really was the cause of that dementia. So how do we find a cure to something that can be caused by 55 different things, right? We had two lists, the intracellular, the extracellular, and then we said it can be mixed, right? So we can have a little bit of Alzheimer's, a little bit of vascular, and a little bit of alcohol, and we're going to have a mixed dementia. Well, how are we going to treat that, right? Or how are we going to know if the treatment we're treating, if it's working on the Alzheimer's side but not on the vascular side, or on the alcohol side but none of the other two? So it gets really hard to do research, because we have to try more and more to sort of purify the type of dementia we think it is, right? So that then we can really measure the treatment impact on that type. Because if it's a mixed type, it's going to be really hard to know if we were successful or not. So typically the research cycle is, we take brain cells in a bottle, we drop in some chemicals, and then we see what happens, right? That's how it starts. We got to try it in the lab and change something about these cells in the lab. If something cool happens, then we go to mice. And we look and see what happens to the mice. If they all die, probably shouldn't give this to humans, right? If it seems to make a little bit of a difference, that's good. Then what we're going to do, though, is then we have to go to the human side. So look under the microscope, try some mice, and then we go to 10 people. Because if this is really bad, really good for mice, but really bad for people, we got to find out real fast. And so we only try it on 10 people. Right? And then we see what the side effects are. If nothing bad happens, then we do a couple of hundred. Because those 10, they don't represent the world. A couple of hundred, though, now we start getting, some people that have this problem or that problem or whatever, right? So we have a better chance of seeing if something bad happens. If it makes it through that, only then do we actually do the clinical trial, which is now thousands of people around the world, right? And so we recruit from around the world, and half of them are going to get the sugar pill, half of them are going to get the ingredient that's active, and then we're going to follow them over 6 months to 2 years to see which group does better. And it's hopefully the one we're treating. Because if the one that we treat with sugar does better, then that's really bad, right? So that's how the research cycle is. So this takes decades to do well, right? So since 2007, there hasn't been a new success. One thing about research that it's a bit abstract, but I want you to just look at this graph, okay? Now, you see this blue line starts going up, and then this red line starts going up. And it goes higher and higher, and the red sort of follows what's happening in the blue line. So how many people here think that what's happening in the blue line is causing what's happening in the red line? Anyone? Looks like it, right? So it turns out that we're looking at ice cream sales and shark attacks. How many of you think that eating ice cream causes a shark to attack you? Right? What's happening, of course, is that there are months when we don't spend a lot of time in the ocean and we don't buy a lot of ice cream, right? Now we get to the summer and we do both. So there's absolutely no relationship between ice cream and shark attacks other than that it's summer, right? So if we say these people are losing their memory and these people also have plaques on their brain, does that mean the plaques are causing memory loss? Or is there something else that's causing both, right? And so that is the challenge in this research, because we know there's things going on with amyloid. We know there's things going on with tau, but we don't know what's causing what, or is there something completely else that's causing it all, right? And that makes it really hard to fix. Now, observational studies are cool because we don't make anyone do anything, right? In a trial where we actually give half of you real pills and half of you sugar, we're controlling the environment. Observational studies are cool. We just say, okay, everyone who eats poutine more than 3 times a month, sit on this side of the room. Everyone who eats it less than that, sit on this side of the room. You sort yourselves out. We do memory tests to all of you, and then we can judge the impact of poutine on the brain. But it's going to be more like our graph of red and blue lines, because all we know is that maybe because you eat poutine, you also drink Coke, and you also smoke, and you also drive a motorcycle. I don't know, right? So we don't know what all those other factors are. So observational studies are good. We start separating out groups, but it's not going to give us the same level of information. Now, the other thing is we say, okay, now I want to really know if poutine is good or bad for the brain. So now I'm going to say, you guys are going to eat poutine every day. You guys are not going to eat poutine at all for the next year, right? You guys all want to move over here, right? So the thing is, you can't do that, right? I can't make you eat a certain diet. So how are we going to actually be able to say, is poutine good for the brain or not, right? So that's where observational studies are the best we can do. We can't stop people from reading. Is reading good for you? You guys get to read. You guys don't get to read anymore, right? You can't do that, right? We can't. So we'll never really know unless we do observational studies. So they have a role, but they're not going to give us all the answers. All right. So let's go back to the amyloid and the tau. I think I'm going to the Alzheimer's conference tomorrow in Los Angeles. There'll be tons of talks about amyloid. There'll be tons of talks about tau. It's because everyone pretty much agrees this is part of the story. So let's start at the beginning. Let's measure it, right? So how can we do it? Well, the normal thing we do is we do a blood test. Can we take a blood test from me right now and measure my level of tau and amyloid? The answer is no. Well, that's weird. Why not? Well, it's because the brain circulation has a particular filter system that prevents it from getting into my bloodstream. So yeah, it's in my brain, but actually, no, you can't measure it in my arm. That's no good. So, okay, so it's floating around the brain. Why don't we do spinal fluid? Sure, I'll stick a needle in your brain and we'll suck out some spinal fluid. You'll love that. No, we won't do that. So the best we can do, though, is go into the spine. So that it's all connected, the same fluid. So you bend over and I stick a needle in your spine, and as long as I don't go too far and you become paralyzed, well, we're in good shape, right? So we can take some fluid and we can measure it. But again, it's not like taking a blood test. It hurts, but then you get a little thingy and a little sticker, and we're good. But a needle in the spine, it's not trivial, right? So measuring this is actually a real pain in the neck. Now, we have developed ways of doing X-rays for this, okay? So here, right, darker color is bad, or the red, the more red is bad. Blue, green is good, yellow, red is bad, right? So here's a normal brain. Got a little bit of plaque, amyloid happening. Here's someone with mild cognitive impairment. Oh, actually looks better than the normal person, doesn't it? Right? Problem. Right away, you have a problem, right? It's not a perfect solution. Then we go to mild cognitive impairment at an advanced stage. This person is about to transition to dementia. A lot of red. Here's the person with dementia. It looks like they have less red. Well, they do because the brain cells are dying, but so how am I supposed to know, right, just from this test where you're at? Well, that's the problem. We don't have a perfect test. This is tau, right? So a healthy volunteer, and then here we have the person with Alzheimer's. Yeah, these are two, and it's easy to see, but if I show you 100, you're going to have a hard time differentiating which one's which. So just measuring the tau and amyloid is a real problem. It's a real complicated thing. Let's say, okay, forget it. Who cares, right? Who cares how much tau and amyloid you have in your brain? I mean, we do care, but let's just get rid of it, right? So let's just develop medications to get rid of the tau and the amyloid. So how can we get rid of it? The first thing is let's not even produce it. So we learn the chemistry, how to make amyloid, and then we go, let's stop the process right here. Bam. Put in a little chemical block. We won't make amyloid anymore. It'll cure Alzheimer's, right? Well, we did that, and it didn't work, right? It stopped the production of amyloid in mice, but it didn't change the people who had it, their development of their dementia. Okay, so what if it accumulates, and then we say, we'll help the body clean up, right? So I have a cut, bacteria get in it, it gets infected. What does the body do? It sends antibodies. So these little proteins, they stick on the bacteria, the white blood cells come, they chew up the bacteria, Bob's your uncle, everything heals, I'm good to go, okay? So why don't we make antibodies against plaques? Makes sense. So we did. Spent billions of dollars making antibodies against plaques. Gave them to thousands of people. Some people had brain damage from it, and some people, there was simply no effect. Bad news, right? So this is the vagaries of the research we're doing. This is the complications of the research we're doing, the drug trials we're doing. I don't want to be pessimistic, but I also want us to be realistic, right? That this is going to take a lot more work for us to finish. So I'm just going to show you some other types of research that are ongoing here in Ottawa. This handsome young man is wearing an EEG cap, and what we're trying to do here is measure electrical flow in the brain, right? Remember I told you, we get the cells, they communicate electricity, blah, 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 and then later on we lose our function. Well, can we detect these electrical changes before our function changes? So we have a bunch of research going on with that. And actually, if you look here, the healthy person has a very fast response and then a clear response here. The person with mild cognitive impairment is already showing a delay and less of a clear cognitive response to the stimulus. So this is just, it's another type of research where there's no drugs, but we're just saying, like, if we can detect it earlier, maybe we can intervene earlier. Rather than going to your doctor and having to do that awful memory test, the MOCA or the 3MS or whatever it is that your doctor does, it's stressful, we hate it. What if you could play a card game at home and you could bring the results in? And that'll make it more reflective of you in your normal day. So there is research going on. How can we test? How can we use computers to test brain function? Again, trying to detect early changes in a more fun way than having to do a 2-hour cognitive test. And then there's research in our lab doing technology, and we're using sensors in the home, and we're trying to make the home safer for people with dementia. And so just another type of research. So right now in Ottawa, we have drug trials, for sure. We're part of all the international drug trials, and we need to continue doing that work. We have intervention trials, which is, can we retrain the brain in some way, right? Can we do something other than drugs where we can sort of rewire the brain in a different way? We're using technology to support it. And then we do have a number of longitudinal trials where all we want to do is see, how does it evolve? Like, if you've got a little bit of amyloid and a little bit of tau, what do you look like in 5 years compared to someone that looks like a lot of amyloid and a little bit of tau and all the combinations and permutations, right? So we do need to learn more, so we do need to do longitudinal trials. So we always need more people volunteering to be part of research trials, and through the Dementia Society or through Bruyère, there's lots of ways to do that. Typical intervention is we need to select the right group of people, so there's a screening process. We do baseline testing. We do have to do the sort of those awful memory tests. We do them at baseline. Then we do the intervention, which may be just watching and waiting, and then we do follow-up testing. So that's sort of the typical routine for a research trial. So I'd said earlier on that I was going to tell you the secret to not aging your brain. And there are sort of 5 parts to the story. We've already talked a lot about poutine, right? So eating matters, sleeping matters, and I would say having your health monitored would matter, right? So if you have borderline diabetes, probably it'd be better to treat it earlier rather than later to protect your brain, right? If you have borderline high blood pressure, how would you know? It's a silent disease. We don't feel it, right? Probably better to once in a while go see your family doc or your nurse practitioner or whoever, right? And just have some health monitoring. These are the 3 variables that are always modifiable. Okay, these are things that we can do right now to change how our brain evolves. So let's just go back quickly to, this is the new Canadian guideline. Very simple. Like, this plate represents all the food you eat. Half of it should be vegetables and small fruit. That's easy. Half of every meal, every plate, should be vegetables and fruit. Okay? A quarter can be grains, and the more whole grain they are, right, the better. So white bread, bad. Colored bread with seeds, good, right? And then we need protein. A quarter of what we eat needs to be protein. But how many pieces of red meat do you see? There's 3 little ones hiding at the very top of the plate, okay? That is the amount of red meat we are supposed to be eating. So the steak that covers the whole plate, that's your red meat for the week, okay? So this is not me. This is this is the Canadian food guidelines. This is the new thing. For fruit, small fruit are better. Watermelon is not a fruit. It's fun in summer, but it's not a fruit, right? We want small fruit that are full of nutrients. Sleep, we have this U-shaped graph. Ideal sleep is between 7 and 8 hours a night. If you can start that in your 40s, you're going to do well, right? If you sleep 4 or 5 hours in your 40s, that's your chance of getting dementia, about 5 times as high as the person that's sleeping 7 or 8 hours a night. Okay? So, and if you sleep too much, it's no better. So, sleep matters. We need to clear our brains at night. We sort information while we're sleeping. We think dreaming is part of that, but we're also cleaning up the mess. So if we have amyloid accumulating during the day, at night, we can try and remove some of that, right? Is it a perfect system? No, we know it's not, but if we don't sleep, there'll be no amyloid removal, right? Exercise. Why is exercise so good? Because all of it is around muscles, right? If I do physical exercise, and I try to do a half hour every day, okay? When I do that, I'm drawing my heart into more action. I'm drawing my lungs into more action. I'm breathing deeper, heavier. My heart is pounding more. Guess what? It's all because of my legs and whatever exercise I'm doing, my arms. But who's benefiting? My brain, right? Because the same blood that's going to my legs is going to my brain. Brain's going, woohoo, right? I'm getting what I need. So physical exercise. At the lungs, we're strengthening our diaphragm, we're strengthening our intercostals. We're going to do way better breathing than if we sit around all day, right? I'm not using my muscles. If I don't use these muscles, they're going to fade. If I don't use these muscles, they're going to fade. It's the same system, right? Same with the heart. It's a big muscle. That's all it, well, don't tell the cardiologist I said that, but the heart is a big muscle. Who cares? It's there to pump blood to the brain. That's all. That's all we need, right? So it's a big muscle. We need to exercise it. And then we're good. Exercise also thins the blood. Guess what? Thin blood goes through that little kink in the hose a hell of a lot better than thick, goopy blood. Right? Thick, goopy blood full of poutine. Carrots are good. I have an obsession with poutine, yeah. I own a stand, actually. I want to buy the one in Almont, too. No. So, yes, I have nothing against poutine. I love poutine, but once a month, right? Because I know it's bad. That's okay. I know alcohol is bad, but I'll have a drink on the weekend, right? That's okay. Moderation, though, right? So, exercise. This is a trial, one of about 1,000 trials I can quote you that show the impact of exercise, okay? So this is very simple. Brilliant, right? Very simple. They took 60 people over the age of 60, all the way to 79, and they did a brain scan. They just wanted to measure the size of the brain. They said, okay, here's a bunch of people, let's measure the size of the brain. Then they said, okay, now you're going to do exercise. What? That's not what I signed up for. Yeah, that's what you signed up for. 20 minutes of exercise a day. If you're walking, if that's your exercise, you got a coach, right? If you're walking, 2 kilometers in 20 minutes. That's a good pace, right? It's not kind of, right? It's move, right? You're moving. 2 kilometers, 20 minutes, good exercise. Do that for 6 months, and then guess what? We're just going to do another brain scan, right? And what are we going to find? Well, we're going to find that 6 months later that you've lost 10 million brain cells. And it's going to be shrunk a little bit. Wrong, right? This group that was sedentary before we put them on an exercise program, they grew their brains. How much did they grow their brain in 6 months? 2 years of age they took off their brain. 2 years in 6 months' time, okay? So exercise is real. 100% guaranteed that exercise will be good for you. People have joint problems, people have heart problems, people have lung problems. We'll deal with it, we'll adjust accordingly, but for sure, 100% certainty, more blood to the brain is going to be good, right? Goes without saying. What about cognitive exercises? So this is a bit of a controversial area because people say, all right, if I sit and practice memorizing playing cards, fantastic. I'll be better at memorizing playing cards. But who cares? Does that mean I'm a better, can I do finances better? Does it mean I'm a better doctor? Does it mean that, what does it mean, right? So there's a lot of challenge with training parts of the brain and then trying to extrapolate what does it mean in real life, right? However, this is a brilliant study. They took 2,800 seniors, these are healthy seniors, and they said, okay, we're going to give you a brain training program on a computer. And there's 3 types of brain training. One is memory, one is speed of processing, and one is reasoning, okay? And so we'd be in groups, and some of you were going to do none of that. Some of you are just going to watch videos or whatever, right? And so, lo and behold, they did this for 3 months. And at the end of 3 months, the people that did memory training did better on memory tests. The people with reasoning training, they did better on reasoning. And the people that did the speed of processing training, they were faster. Okay, cool. Maybe not exciting, but cool, right? It does mean you can train your brain, at least for a short period of time. But how long does it last? And what does it mean, right? So then they said, well, let's see how long this lasts. So they did a 5-year follow-up, and then they did a 10-year follow-up. And these people that were in the 10-year follow-up, once a year, they would do 3 more weeks of refresher. That's it, okay? After 10 years, the people that had done memory training, the reasoning and speed of processing were still better at reasoning and speed of processing than the people that had watched the videos. 10 years later. Beyond that, when it came to activities of daily living like banking, shopping, doing your own taxes, they were better at that, okay? And then, as if that wasn't enough, the incidence of dementia in the groups that had done the brain training was lower, 20 to 30% lower than those that hadn't done the brain training, okay? So, pretty powerful stuff. One huge trial. We still need to work on it. We still need to do more stuff, but for now, I am recommending this particular brain training program to my patients. Social engagement. So this is one of these things that are hard to measure, right? We can't say, you guys get to leave the house every day, you guys have to stay home. We can't do that. We can, though, ask people, what does your day look like, right? Do you go to church? Do you go, or synagogue, or whatever that you go to, temple, whatever, right? Are you part of a lawn bowling league? Do you volunteer at the hospital, right? And so they divided these people in Madrid, 1,000 of them, into those groups, 2 groups, those that were active socially and those that stayed home mostly. And what was clear was that at the end of the 3 years, there was a difference in the rate of dementia in the ones that were socially active. So it's observational. It's all we can do with social activities. We can't force you to do something or stop you from doing something social, but it's pretty powerful to know that just that idea, no exercise, no nothing else, right? Just going out socially is brain protective. So I'm still confused. At the end of a year, I've lost 20 million brain cells. At the end of 10 years, I've lost 200 million brain cells. How can it be that exercise, social engagement, that these things are helping my brain, that I'm actually having more brain stuff, material at the end of this? So it's because, although we're losing cells, we're making more connections and we're building the infrastructure. So the cells might be dying, right? Today might be the day this guy kicks the bucket, right? This guy communicates here, this one communicates to here. Maybe we can go from here to here, here to here, here to here, make a new path, grow some more connections. Even though this cell is there, we'll get the job done. It'll be a little slower, but we'll get the job done, right? If we do more connections, then this cell's going to need a little bit more oxygen, so let's build some more capillaries to make sure we get enough oxygen going to that cell. And so the infrastructure gets built. So we have more brain mass, even though we have fewer working brain cells. And that is neuroplasticity, right? So, 5:30, we're right on time almost. We'll wrap up. So this comes from the Dementia Society, right? And this is a recap of the good things we can do for our brain, right? Care for your health so that the whole body health is reflected on good brain health. Be active, physically active, right? Get that oxygen to the brain. Eat healthy. Be social. Challenge your brain. Do brain challenging exercise. Learn another language. Learn a musical instrument. Paint, right? Protect your head, right? And sleep. A word from your sponsors.